Continuing with part 3, which is the limbic system. And the diseases that we'll be taking a look at that directly involve the limbic system are developmental abnormalities, particularly those that occur during ventral induction, commonly involve the midline structures and those structures at the base of the brain. Take a look at limbic encephalitis, the dementias, and finally neuropsychiatric disorders. This young girl was 20 weeks pregnant, and on the fetal MRI, on the sagittal view, you can see a dysmorphic brain. Doesn't look like the brain is developing normally. And the axial views show the typical monoventricle, a failure of midline cleavage, and fusion of the thalami in this patient with alobar holoprosencephaly. Septo-optic dysplasia can also be associated with seizures, and this entity or abnormality is quite variable. Patients, may be almost normal, or they can be blind and have significant involvement of the limbic system. On the images, on the coronal T1 weighted image, there is absence of the septum pellucidum. On the sagittal T1 weighted images, there is atrophy of the optic chiasm. And they're just deficiency of structures around the inferior recesses of the third ventricle and around the region of the anterior commissure. And the anterior commissure just kind of sticks out because there's no other tissue around it. There is associated dysgenesis of the corpus callosum and apparent abscess of the rostrum of the corpus callosum, or blunting of the genu right there, and deficiency of the tissues in the subcallosal area. And these patients commonly have abnormalities of the limbic system and can also have some hypothalamic dysfunction. These images illustrate partial agenesis of the corpus callosum. There is some anterior body of the corpus callosum, but the posterior body and the splenium are absent. There is some vertical orientation of the gyri in that region. And the coronal T1 weighted image shows some of the other classic finding. Eversion of the cingulate gyrus. Cingulate gyrus should be pointing medially. It is pointing inferiorly. And then just medial to the atria of the lateral ventricles are the bundles of Probst, the white matter bundles that never made it across the midline to form the corpus callosum. So partial agenesis of the corpus callosum. Limbic encephalitis is a rare entity, but it's something one must consider if there is dysfunction of the limbic system in a patient who has a tumor. It's a paraneoplastic syndrome, most oftenly associated with small cell carcinoma of the lung, but other neoplasias can also produce this entity. It acts like an encephalitis. It's characterized by memory loss, dementia, involuntary movements, and ataxia. And in the images, you look for abnormality in the limbic system. And here, bilateral involvement of the medial temporal lobes, region of the hippocampus, and also abnormal signal in the region of the hypothalamus around the third ventricle. So limbic encephalitis. Alzheimer's disease, of course, is a major disease that's increasing in frequency as our population ages. And there's a lot of research being done on this to try to develop methods to stop some of these effects. Alzheimer's disease is characterized by severe memory deficits. Pathologically, pathologists see senile plaques, neurofibrillary tangles. There's deposition of beta amyloid and tau protein. Also, one can look for hypometabolism and decreased blood flow in the parietal and temporal lobes. There's a deficiency of the cholinergic producing neurons in the subcallosal nuclei. And that is also a focus of investigation to look for methods, stem cell therapies to reestablish those neurons in the subcallosal nuclei, to replenish those nuclei, to to increase production of acetylcholine. Nothing that's been too successful yet, but it is a focus of research. Alzheimer's disease is characterized by atrophy of the hippocampus, amygdala, entorhinal cortex, again, a very important area in Alzheimer's disease. And atrophy in these regions is 10 times faster than normal aging. And so these are areas to look for on the images to see if there's disproportionate atrophy of these structures compared to the rest of the brain. Imaging, nothing specific at this. To make this diagnosis requires clinical correlation and neuropsych testing, but one can use MRI. PET to look at metabolism, SPECT, and other measures of blood flow to look at blood flow within the temporal parietal regions. Spectroscopy can show elevated myoinositol. Unfortunately, it's not sensitive enough to make early diagnosis of Alzheimer's disease. So it's not helpful during the early stages. And as an example, a case from one of our research studies. In a patient with Alzheimer's disease, shows a marked dilatation of the temporal horns, and the coronal views show marked atrophy of the hippocampus, much more atrophy of the hippocampus, as well as dilatation of the temporal horn, but disproportionate atrophy of the hippocampus compared to the rest of the brain. In evaluating patients with mild cognitive impairment, the fear is always that they might be developing Alzheimer's disease. And one way to predict that is to do serial imaging, where you do quantitative analyses of the hippocampus and the temporal horn. And one measurement is not so helpful, but if you get serial measurements showing reduction in volume of the hippocampus, that's pretty good evidence that the patient is going to go on to develop Alzheimer's disease. Frontotemporal dementia is distinct and has a different clinical presentation. If it's associated, if they do a biopsy and it's associated with tau protein, then it's classified as Pick's disease. Frontotemporal dementia is characterized by deterioration of personality, behavior, and judgment. The memory is preserved until later stages, so that helps distinguish it from Alzheimer's disease. The imaging is not always specific, but in this case, it was quite classic, with marked atrophy of the temporal lobes and the frontal lobes, but the relative preservation of the posterior lobes of the brain, consistent with frontotemporal dementia. And finally, neuropsychiatric disorders. The Time magazine in August 2003 featured the 5 bipolar disorders, and these psychiatric diseases are getting more attention, and a lot of research is being done to better understand these diseases and to develop therapies against the symptoms. So we'll take a look at anxiety disorders, schizophrenia, affective disorders, the bipolar disorders, and psychopathic disorders. A lot of research is being conducted at UCSD on the anxiety disorders, and this includes the panic attacks, phobias, stress disorders. We know that the amygdala attaches emotional significance to sensory input. And the neuropsychologists and psychiatrists in their research have come up with this theory of fear circuitry. The amygdala modulates the neural circuitry in orbital, ventral, and prefrontal cortex, the anterior cingulate, and the entorhinal cortex, all structures involved with anxiety disorders. And the theory is that there's failure of the anterior cingulate and hippocampus to modulate the activity of the amygdala. So the amygdala gets out of control, causing these anxiety disorders. On fMRI, there's overactivity of the amygdala during facial recognition tasks. Schizophrenia is one of the most studied psychiatric diseases. It has many fascinating symptoms and clinical parts. It's still a mystery, but we have learned some things. There is decreased anterior cingulate volume and reduced NAA on spectroscopy, NAA being N-acetyl aspartate. An fMRI decreased amygdala response during facial recognition tasks, so the opposite of the anxiety disorders. Decreased size of the hippocampus, deficit in working memory, decreased activity in the dorsolateral prefrontal cortex, and there is the cognitive dysmetria hypothesis, where there's disruption of the cortical, thalamic, cerebellar, cortical loops. But so there's not one area of the brain that you can point to and say this is the cause of schizophrenia. It seems to be multiple parts of the limbic system and other parts of the brain that contribute to this psychiatric disease. We know more about affective disorders and the bipolar brain. And this diagram comes from that Time magazine article. And we know that the prefrontal cortex regulates emotion, processes rewards and motivation. The ventral striatum also processes rewards and assists with judgment and behavioral decisions. The amygdala, again, attaches emotional significance to sensory input. Hippocampus, memory processing. Subiculum distinguishes danger versus reward situations. And very important in this disease are the raphe nuclei that are dispersed along the midbrain and pons. And the raphe nuclei are responsible for producing the serotonin and dispersing the serotonin throughout the limbic system. And of course, in the affective disorders, there's a deficiency of serotonin. So the raphe nuclei are an important component of this disease. And depression, abnormal things that we've learned about: the decreased serotonin levels, increased ventricles, and white matter hyperintensities. UBOs, it's a term we use for unidentified bright objects. We see these hyperintensities in the white matter and not exactly sure what they are. Decreased frontal lobes, basal ganglia, amygdala, and hippocampus. Decreased activity of the prefrontal cortex and the anterior cingulate. So kind of the opposite of what's seen in the anxiety disorders. But again, part of the limbic system, and these diseases are definitely intimately related to dysfunction of the limbic system. Severe depression, there's the theory of Limbic-Cortical dysregulation, the theory that was proposed by Mayberg in 1997. And the theory is that there's hypometabolism in the dorsal compartment, prefrontal cortex, anterior cingulate, inferior parietal, and striatum, producing the symptoms of apathy, attention deficits, and psychomotor slowing. And hypermetabolism in the ventral compartment, the hypothalamus, insula, subcallosal region, and brainstem, resulting in disturbed sleep, appetite, and libido. Finally, the psychopathic disorders, and I call these the professor disorders because it's not uncommon symptoms you see with the professors: impulsive and aggressive behavior, deficits in informational and emotional processing, and malfunction of the neural circuits in the prefrontal and temporal limbic regions, which are important for emotional learning. If you have not found our website, this is our Neuroradiology teaching file. This is the address, the URL. There are about 400 cases on the website. There is, you can review those cases, and there's little text associated with the cases. There are also some normal anatomy. All my syllabi are on that website, including a syllabus for this lecture. So please take a look at the website. It's free, it's open. You can log on from anywhere in the world.